and welcome to Nursing School Explained. In this video on diabetes insipidus, that is sometimes also referred to as water diabetes. Now keep in mind, it has nothing to do with diabetes type 1 or 2. It's just another disorder that affects the kidneys. In order to really understand how this mechanism of altered ADH or antidiuretic hormone works, let's review the pathophysiology or the physiology of how ADH usually works in our bodies. So we have the hypothalamus that then stimulates the pituitary gland that is divided into the anterior and posterior part. And from the posterior pituitary gland, under normal conditions, in response to low blood pressure or increased serum osmolarity, ADH, antidiuretic hormone, is secreted. It then stimulates the kidney to increase the reabsorption of sodium and water, and if we have more water in our system, it will bring up the blood pressure. Now that is the normal mechanism of how ADH is supposed to work. Now if we have too much ADH secretion, then we have syndrome of inappropriate ADH, but if we have too little ADH, then we are dealing with diabetes insipidus, which is what we're going to look at in detail here. So for causes, there can be basically two different things that are happening. So there can either be decreased ADH production by the pituitary gland. That can usually be because of a brain tumor, head injury, any kind of central nervous system infection, as well as brain surgery. Or it can be a decreased renal response to ADH. And that is usually due to renal damage that can be due to renal conditions such as pyelonephritis or any kind of obstruction of the urinary system, but it can also be due to nephrotoxic drugs, and lithium is a specifically damaging medication to the kidneys that can lead to diabetes insipidus. And then are also what are called psychogenic causes of diabetes insipidus, which would be increased or crazy amounts of intake of water, which can be psychological disorders as well as any kind of thirst center disorders. And therefore the patient will just drink water, and then everything will be diluted in their system. So signs or symptoms of any of these causes of diabetes insipidus will be polydipsia and polyuria. And this can be a significant amount of urine that this patient is producing, anywhere from 2 to 20 liters per day. Now, if we're excreting that much urine, it's going to be very dilute, right? We're going to be drinking a lot of water. We're not really having all these electrolytes that are concentrated, and then we're going to just basically excrete all that urine, meaning that the specific gravity is going to be very low, so less than 1.005. Now, along with any of these disorders with ADH, we have to keep in mind that the goal really under normal functioning would be sodium and water reabsorption. And whenever sodium goes out of balance, whether it's high or low, keep in mind it always causes neurological symptoms, and they may be as little or as mild as irritability or headache, but they might lead to altered level of consciousness, seizures, and maybe even coma if the sodium gets way out of balance. And then for diagnostic tests, so if the patient presents with these symptoms, usually the serum will be very concentrated because the patient is just excreting so much urine that there's basically now fluid volume deficit in the patient's body, evidenced by serum osmolarity greater than 295, so very concentrated, as well as a serum sodium of greater than 145, which is typically the upper borderline. And then again, this urine specific gravity that is less than 1.005. So now we're losing a lot of water, which means that the urine is going to be very dilute with very little particles in there. But because we don't have any more of that volume of that water in the body, it'll be very concentrated, evidenced by the serum osmolarity and hypernatremia. And then there is a test called the water deprivation test. So basically the patient won't be given any water for about 8 or 12 hours, and then they will be given ADH, a synthetic form of ADH, And if that leads to then decreased urine output and increased specific gravity, so basically now we are responding to ADH, which is the normal response, that means that the water deprivation test is going to be positive if we have cerebral causes. So if there is a problem with the pituitary gland, because now we're giving the patient ADH and everything takes its normal course, and everything goes back to normal in terms of fluid and water balance. But if there is no response to the ADH that we're given, that means that the cause of the problem is usually the kidney. And then there's different treatments depending on what the cause is. So the water deprivation test is a very good test here to see, is it a cerebral cause from the pituitary gland or is the problem within the kidney. As for treatment, so if it's a cerebral cause, then the patient is going to have to get fluid replacement. Remember, they're just urinating all the time. They're losing a lot of water, losing a lot of fluid, so we'll have to replace that. And that can be PO or IV with hypotonic saline or D5W, and then it's usually titrated to urine output. So if the urine output then it gets balanced out, then we can decrease the fluid administration. And then we can, the treatment is administer DDAVP, which is the synthetic form of ADH, and that can be given by various routes. It can be given orally, IV, subcutaneously, or nasal spray. And typically, once the diabetes insipidus is under control, but we know that it's a cerebral cause, the patient most likely will have a nasal spray that they go home with as a means of self-administering that ADH that they are lacking, so that they're not ending up in a crisis, in a hypovolemic crisis. But if the cause is the kidney, so if now we've done the water deprivation test and there's no response to this synthetic ADH, then the patient will have to go on a decreased or low sodium diet. They will also have to be on thiazide diuretics with potassium replacement, because otherwise they're at risk for hypokalemia. And if there's no response to that, indomethacin sometimes helps. That's an NSAID. Sometimes helps to increase the renal response to ADH, so now that all these other mechanisms can go back and to be balanced. And as for our nursing care, remember, when we're dealing with any kind of fluid volume problem, we always want to monitor vital signs, specifically heart rate as well as blood pressure, daily weight and eyes and nose to check for fluid balance, as well as neurochecks, because we know diabetes insipidus can cause hypernatremia, and we know that sodium levels can be or are very indicative of mental status changes. So if the patient presents with very vague mental status changes, we always have to think about a sodium imbalance. So neurochecks will be very important to determine, as well as checking the urine-specific gravity to see if we're making any progress with any of these interventions that we have done here, to see if the urine is now becoming more concentrated and that ADH is actually working. So thank you for watching this video on diabetes insipidus. If you haven't already done so, please also watch the video of the opposite disorder with increased ADH, which is called SIADH, or any other videos in the endocrine playlist. Please subscribe to my channel, give me a thumbs up if you like this video, and I'll see you soon here on Nursing School Explained. Thanks for watching.